Good morning and welcome. My name is Zachary Silverman. I'm on the vascular access team here at Duke Regional Hospital, and this is my synthesis proposal. So the breakdown of this presentation, we'll be going through an introduction of the problem, literature review that I was able to find on the problem and how we can potentially resolve that. The goal of this presentation and the goal of this assignment, our proposal statement, the interventions that we're proposing, and the implementation of how those interventions would roll out, as well as the conclusion. So the introduction is that we see a lot of DVT, deep vein thromboses in the ICU setting. We place PICC lines, so this is a common PICC complication, and we really do our best to communicate this to the providers in the ICU, as well as the ICU nurses. But we feel like there's a breakdown in communication because oftentimes they'll continue to order PICC lines on patients that clearly are at risk of complications from a PICC. And yet, even though we tell them kind of our experience with PICC lines in these patients, the ICU providers will still kind of, not to say force our hand, but they push us to put these central lines in that we know are going to cause complications for the patients. So we're trying to improve our communication as well as potentially offer some better interventions for the ICU to provide the right catheters for the patients. It can be a little frustrating because as nurses we pledge to do no harm, and yet when we put these PICC lines in, we sometimes know before we even place them that we're going to be causing DVTs, and 3 days to a week later we find out that patient now has a DVT, and it can be a little upsetting for the VAS team because we really are trying to offer what's best for the patient. So of course a lot of that was anecdotal, so I did some literature review to look into this, and what we found was that PICC lines are much more, or have a higher risk of DVTs in the ICU setting in comparison to things like IJ-CVCs and femoral CVCs. And ICU patients oftentimes are only there for in the ICU for a period of time, so it's a great time to put a short-term catheter in, venous catheter in, like a IJ-CVC or a FEM-CVC, and then we can think about a PICC line once the patient's more mobile and has a lower risk of those DVTs. So the Michigan Hospital Safety Consortium in 2022 created this Me-PICC score, which is actually an algorithm to look at how high of a risk a patient has for getting a DVT from a PICC line. And we were thinking that if we were to implement this Me-PICC score, it could improve our communication with the ICU providers, and perhaps give a more objective way of identifying whether a PICC is appropriate or inappropriate for a patient. Another thing that we found in the literature review was that nurses in the state of North Carolina can place IJ-CVCs, and we were thinking perhaps if the providers don't want to place them, but they can acknowledge that these IJ-CVCs might be more beneficial than a PICC line, we as the VAS team could be trained to place these lines for the ICU. So the goal of this proposal is to improve patient outcomes by lowering the rate of CVC-related complications in the ICU setting. And that's really what we're here for. We're really trying to put the patient first. It's not we're not trying to push against the doctors. We're just trying to always put the patient forward. And that's what this proposal is all about. So our proposal statement is the implementation of the Me-PICC score can guide communication between VAS and ICU providers regarding catheter selection utilizing evidence-based practice. And so that would guide us just to decide what is the best catheter for the patient. And then similarly, we can offer, or to offer the ideal catheter for the patient needs, VAS aims to become credentialed in the placement of IJ-CVCs in effort to lower DVT rates and other complications in the ICU setting. So our first intervention would be to work with the ICU attending as well as the ICU nurse specialist to help implement this Me-PICC score. And what that would hopefully do is direct us to come up with the appropriate catheter for the patient, hopefully decreasing DVT rates as well as improving patient outcomes. So this is just the Me-PICC score, just a nice display of it, and we were thinking that we could have this provided to the ICU for both the nurses and the doctors to look at. And when they're deciding on a catheter to order, they can look at this ME-PIC score, which is a pretty simple algorithm, just adding up points based on do they have another CVC, do they have an increased white count, do they, how many PIC lumens will this PIC that they're planning to order have? Do they have any histories of DVTs or any active cancer? And that point system will help to decide whether they're class 1 or low risk, class 2 or intermediate risk, class 3 or high risk, or class 4 of extremely high risk for PIC-related DVTs. And then to follow up with this intervention would be to perform audits looking at the PIC-related DVTs versus IJ-related DVTs, and hopefully that will better identify the appropriate catheter for patients moving forward. The other intervention would be to teach and roll out vast education for placing IJ-CVCs. As we discussed, nurses are well within the scope to place IJ-CVCs, but we do need credentialing, so we'll need the backing of Duke to perform these. But we do think that giving us a little bit more variety in what catheters we can offer, we can better help the ICU as well as the patients to give them the correct catheters to lower their risk of complications. Similarly, we would follow up with audits based on IJs versus PICs and look at how many complications are coming up either through DVTs or CLABSIs rates for those patients. So in conclusion, PIC-related DVTs in the ICU setting are higher than the rest of the hospital. That's something that we really want to work on. We think that the adoption of the ME-PIC score can decrease catheter-related complications and improve patient outcomes. We also think that vast credentialing for IJ-CVC placement can help improve patient outcomes. And we think that we'll follow up with post-implementation audits to follow up with these interventions and make sure that they're working towards our goal of decreasing patient complications. Thank you for your time, consideration. Do you have any questions?
What are the barriers to providers placing IJs in the ICUs right now?
That's an excellent question. We don't know. We oftentimes point to other catheters when we're having these discussions about a PIC being inappropriate, whether because their GFR is low or their white count is high or they're paralyzed, all reasons that we'd be concerned to place a PIC line. And when we bring these things up, a lot of times providers still say they want a PIC. And we point out all the reasons why PIC is putting the patient at risk for complications. At the end of the day, it's not our decision, but we do want to, we are a specialty team and we know a lot about veins and venous access, and we take a lot of pride in that, and we want to offer the patients the best catheters we can. Sometimes it's not catheters that we are trained to place. So we push the providers in that direction, but oftentimes they can be quite bullish in what they want. And I'm not trying to throw any providers under the bus, but it is common where when we place a PIC line on a patient that we've clearly said this is not an appropriate order, they wind up with a DVT or a CLABSI, or nephrology is upset because we put a PIC in a patient with a low GFR. So I don't know what the barriers are. I don't know why they don't want to place nearly as many. I used to work in the ICU setting in a different ICU where they were much more willing to place lines. I don't know, and that's why we want to just adopt the skill so we can help them in that way.
Is there currently a script that the VAST team uses at regional when speaking to the providers?
There isn't, and that's why I think that the ME-PIC score could really be beneficial. It could help with just providing an objective algorithm that we can work off of, as opposed to just saying, INS, or Infusion Nursing Society's research seems to indicate that this is inappropriate. I think that sometimes they think that that's not as valuable of information as we would like it to be to them, and so oftentimes they just continue to tell us that they're ordering a PIC and they want to place this. They'll write any note they need to make sure that we place this PIC line, even when we're telling them there's a lot of reasons why another central catheter could be more beneficial at this setting.
Are patients and family members made aware of the risks before before the PICs are placed?
Certainly, we have a consent process when we place PICs or prior to placing PICs, and we talk with the patient if we can, if not, the next of kin, and we discuss with them all of the complications. And oftentimes we are quite honest when we tell them, a patient's going to be at higher risk of a PIC-related DVT because of the fact that they're not moving. Because that's one thing we recommend in our education post-PIC placement is that we all want them to move their arms. We want them to be getting good circulation to decrease that risk. So when you're in the ICU setting and you're paralyzed or something, you really are just at such a high risk for a DVT. And IJCVCs as well as FEMCVCs go in larger veins, so the risk of the catheter-related DVTs are significantly lower, and our research seems to indicate that as well.
Thank you for answering my questions.
Yeah, thank you. Thank you for your time and consideration. Here are my references, and I can email those to you if you'd like.
Yes, please.
Great, well, thanks again.